Thanks for listening. My name is David Hardy. I'm going to talk about a vascular surgery topic, peripheral arterial disease, critical limb ischemia, and aortoiliac occlusive disease, which are very similar disease processes. It's very difficult to talk about all of these things in the hour that I'm allotted. So I'm going to give a quick overview about the workup and management of these. I have no disclosures. And my objectives today to discuss peripheral arterial disease is to define peripheral arterial disease, or PAD, as I may use the rest of the talk, how to diagnose and manage PAD, and discuss some of the treatment options. And our ultimate goal is to keep our patients on 2 feet. As you can see, PAD is a progression of disease which can start from asymptomatic patients, leading to claudication, rest pain, and all the way over ultimately to amputation if it gets bad enough. And today we're going to talk about all these terms and maybe how to prevent the amputation there on the right. How big is the problem? It's pretty large. So it is $3.9 billion in this study from 2008. It compares with our congestive heart failure dollars that are spent by Medicare in that year, and it's only getting bigger. In its relative mortality rate in 5 years, you can see that PAD, at least in these American Cancer Society diagram here, it is pretty close up against, it beats breast cancer, Hodgkin's disease, and prostate cancer. And it's right up there with colorectal cancer as far as mortality in 5 years. So it's a significant disease. And how do we define PAD? Well, it's simply an arterial or an ankle brachial index less than 0.9. And you guys probably remember what this is, but here's a view of what that is. It's the cornerstone of the PAD diagnosis. And the ABI, which I'll use, so you can see here, the rest of the talk is ankle systolic pressure over brachial systolic pressure. And we'll go more detail as we go through the diagnostic modalities about which one of these we take. But typically, when you get this ratio greater than 0.9 is normal. Most people are above 1 and between 1 and 1.4. 0.4 to 0.9, and there's a little differences in these numbers, but that's usually peripheral arterial disease. And then less than 0.4 is typically patients who have rest pain or ulceration. It's very common, about 4.3% of the population, and that's up to 12 million Americans, and even more common in these patients over 70 years of age as it gets more prevalent as we age. It's important because even asymptomatic patients who have an ABI less than 0.9, have PAD, have a decreased life expectancy. And in patients with stable, in these patients with stable and asymptomatic PAD, their MI rate is about 20% in 5 years, and their death rate has been reported as high as 30% in 5 years due to a coronary disease, as a lot of these patients, or PAD, acts as a marker for disease in other vascular beds, such as coronary artery disease. The etiology for this, there is a pretty big differential diagnosis in patients with rest pain or tissue loss or peripheral arterial disease. Atherosclerosis, or hardening of the arteries, is the most common cause of PAD. There are these other variants, which I would not have time to add to this 1 hour talk, but Berger's disease, peripheral aneurysms, Takayasu's aortitis, any arteritides or arteritis, FMD, fibromuscular dysplasia, remote trauma, radiation arteritis, emboli from other places in the body, popliteal entrapment syndrome, and adventitial cystic disease. You may see the last two more commonly in younger people, and that's something to think about if a young person shows up with chronic claudication or worsening claudication to rule out those disease processes. The natural history of this, we talked about. The PAD presentation is someone who may have an ABI less than 0.9 or may have symptoms. If you have someone with less than 0.9, you can see that's about 50% of the patients with peripheral arterial disease. Another between 10 and 35% of these patients, initial presentation, have claudication. Some have atypical pain. That's kind of harder to tell and harder to tease out. And then luckily, about 2% of the patients who present with PAD initially have critical limb ischemia. And we'll define that more in just a moment. But the reason that's so critical is once you have critical limb ischemia, the 1 year outcomes are pretty poor. In 1 year, about a quarter of these patients will have an amputation if nothing is done to these patients with critical ischemia. A quarter of those patients may have cardiovascular related mortality, and about 50% of those patients will be alive with 2 limbs, and those are pretty sobering numbers. As we talk about that progression of disease we showed on that first picture, patients who are asymptomatic who may go to claudication and then progress to rest pain, tissue loss. I'm going to go through those definitions right now. So once you're diagnosed with peripheral arterial disease, how do you know these patients in their history to have that? Well, some of them may have claudication. Claudication is a fancy term that means, it's a Latin term that means cramping or to limp when walking. And it's typically characterized by pain, cramping, or aching that occurs with exercise. And this is a very reproducible symptom. It usually happens at almost the exact same distance, and these patients will recover about the exact same time, and it happens over and over. This means that the patient has insufficient blood supply to meet the metabolic needs of the contracting muscles. Their symptoms are generally one segment below the level of arterial occlusive disease. So if the patient is cramping in their calves, they may have femoral popliteal disease, or if they're cramping in their buttocks, they may have aortoiliac occlusive disease, and we'll talk more about these as we move through this talk. The walking distance may decrease as the disease progresses and as time goes by. In these patients who do claudicate and have the cramping, the ones that are less than 40 years of age, typically their disease distribution is different. And most of these patients who are younger will have aortoiliac disease segments. About a quarter of them will be femoral popliteal, and a quarter will be multi-level. Patients who are over 40, which are the majority of the patients you're going to see in this disease process, have femoral popliteal disease, and the aortoiliac disease segment multi-level are not as prevalent. When talking about claudication, you have to differentiate vasculogenic claudication, which is what we're focusing on here. So that's where we're going to spend most of our time, but there is a neurogenic claudication. What is the difference between the two? And I point this out just in case you have these patients, but vasculogenic is usually reproducible at that same distance every time. It may progressively get worse, but typically it's the same distance where they start cramping. The etiology is typically a vascular issue, and the treatment it depends. We'll actually talk about that a little more as we go through. Cardiovascular risk optimization is key, and surgery may be on the table. Neurogenic is variable. These patients could actually walk 100 feet one day, a mile the next day. They may be at different positions. So these are the things that tease out in our history and present illness. And the etiology is generally a nerve compression, common location in the lumbar region with this. And the treatment's completely different. It's NSAIDs or anti-inflammatory medications, physical therapy, and possibly spine surgery. So it really has nothing to do with the blood supply normally. To talk about this is a little out of order, but we were talking about progression of asymptomatic to claudication. Well, the next category is critical limb ischemia in these patients with PAD. And it's a simple definition. Critical limb ischemia is greater than 2 weeks of rest pain, ulcers, or tissue loss with the increased risk of loss to limb and life. And this is where you escalate the disease process. And this is where you have that about 2% of these patients presenting where they are really high risk of losing their lower extremity. It is significant. It affects about 250,000 Americans per year. And once these patients have an amputation from CLI or critical limb ischemia, I may use CLI interchangeably throughout this, their 1-year mortality rate increases to 45%. So it's a significant disease process. Now we say critical limb ischemia is characterized by that 2 weeks of rest pain or tissue loss. Well, rest pain is characterized by pain, or it presents as pain or burning across the heads of the metatarsals. Usually, this is classic. It occurs at night, it wakens patients from sleep, and it can be relieved by dependency, meaning these patients, if you listen to them, they'll tell you that they've been sleeping in a recliner for months because they drape their legs down in the recliner and the position is better, or they find themselves draping their legs over to the side of the bed, or just simply standing up at the bedside and allowing gravity to help get blood to the foot. That it helps them out significantly. And what this is there now is definitely insufficient blood supply to meet even the basal metabolic needs for the sensory nerves, and that's where the pain's coming from. And these symptoms are usually due to decreased cardiac output and loss of effects of gravity. This indicates severe ischemia, and these patients, like we said, about a quarter of these patients will have limb loss within a year without treatment. This tissue loss is the next thing, the next part of the critical limb ischemia. You go from claudication, rest pain, and tissue loss is kind of the next bit of the spectrum with critical limb ischemia. This tissue loss is, we can say gangrene. It could be dry or wet. Wet usually just means infected tissue loss. The tissue loss can be limited or extensive. I mean, this can be just the tips of the toes. It could be the entire foot or different portions of the leg. And it just depends on where these patients have these ulcerations start. The treatment is immediate tissue removal in these wet or infected gangrene patients. And the prognosis, again, is just not so great. At 1 year, about 0.25% are amputated and about 0.25% have some type of cardiovascular-related mortality. How are these patients classified? There have been a lot of classification systems over the year. These are a couple of the common ones that are used, the Fontaine or Rutherford. Most of us all know the Rutherford, and that's what I would stick to, and that's what I generally do stick to in the sense of peripheral arterial disease with critical limb ischemia or claudication. It's, as you see here, the grades or categories are 0 through 6, 0 being asymptomatic, 1, 2, and 3 is mild, medium, severe claudication. And then 4, 5, and 6 is ischemic rest pain, minor tissue loss, major tissue loss. So it's pretty easy to remember. 0 is nothing, and then you got mild, medium, severe claudication, rest pain, minor tissue loss, major tissue loss, to look at it that way. I'm going to put a couple of slides in here and kind of focus you on this. This is not interchangeable, and I don't use this word interchangeably when I specifically talk about limb ischemia, but chronic limb-threatening ischemia. That is a push toward what we talk about when we talk about a diabetic patient with maybe a critical limb ischemia, a tissue loss, or a rest pain. These are some pictures just thrown up there as I talk through this. This is a little different process. As a patient had critical limb ischemia, that term was initially coined in 1982, and it was never really meant for patients with diabetes. Chronic limb-threatening ischemia, I specifically use that different than critical limb ischemia because it includes diabetic patients, and the critical limb ischemia was not initially meant to evaluate diabetic patients. And since our diabetes population has grown, it was important to add this Society of Vascular Surgery Wi-Fi guidelines: wound, ischemia, foot infection. And that's what that WIFI, wound ischemia foot infection classification. And it typically grades these with wound, as you can see here, 0 to 3, ischemia 0 to 3, infection. And it's simple. And once you have these patients graded, you can put them on a chart and figure out the higher their Wi-Fi classification, the more likely they would have an amputation, or maybe wouldn't be able to be revascularized. So it hopefully is a staging classification, and it's picking up and people are talking about it more, but I'm only going to use that briefly to mention because I think chronic limb-threatening ischemia is way different than critical limb ischemia in my mind. And there's no other classification system yet like Rutherford or any of the UT classification systems that sufficiently incorporate all the etiologies of threatened limbs, and that's what the SVS guidelines or SVS Wi-Fi classification try to do with the wound, ischemia, and foot infection. So the patients show up. What are their history? Typically, they are asymptomatic, 50% of them, but some of them may have pain, and we need to find out the character, location, onset, and the factors that aggravate or relieve. And that location being where it is in the calf or the thigh or the buttocks can tell you maybe the location of where their claudication or their disease is. Their activity level, how far they can walk, and then you ask about other manifestations of cardiovascular disease, their risk factors, et cetera. And these risk factors we'll talk about in detail, but about a quarter to 30% of these patients with PAD have diabetes, and we have to ask about that. What are the major risk factors? Well, smoking and diabetes are about a fourfold or have an odds ratio of approximately four of causing peripheral arterial disease or being related. And those are things you can do something about. Smoking, you can stop smoking. We can have these patients stop smoking. I think that's critical to discuss that with them. Diabetes, we can control their sugars. High blood pressure, we can manage that. Dyslipidemia, but there's not much we can do about gender, age, or race. Some of these other issues that are risk factors for PAD. There are the non-modifiable and modifiable, which was I was alluding to on the last slide, and this is just a little more more of a complete slide with these non-modifiable and modifiable risk factors, as you can see here. Physical exam findings, what do we find on these patients? Well, we have diminished pulses, would be in a patient who may have cramping or leg pain. That would clue you into peripheral arterial disease or lack of pulses. You can get thickening of nail beds, hair loss, and that hair loss is typically due to atrophy of the sweat and apocrine glands where the hair is kind of produced and has that oily substance with it. The reason is the patient is losing blood supply or having this low-lying ischemia where these glands die and they just can't produce the hair anymore. So these are telltale signs of peripheral arterial disease. Dry, scaly feet, ulceration at the tips of the toes, gangrene, and dependent rubor. This is a picture of dependent rubor when you see these patients in your clinic. The reason I put this in is because a lot of patients will come to you with dependent rubor and peripheral arterial disease. They may even have some ulcerations, and these patients may have been treated with antibiotics for a few months thinking it's cellulitis, as you can see the redness of this foot. But I'm here lifting this foot up, and one easy way is to have the patient lie down and hold their foot up for 30 seconds to a minute. But because we are in a time crunch with this talk, I'm kind of pushing the blood out of the foot and assisting it along so you can kind of see that the redness all resolves with gravity. And if this was cellulitis or infection, this patient would not, the cellulitis would not resolve with elevation of the leg. And here's a picture before with the foot down, dependent rubor, and this was with elevation. So you can easily differentiate between dependent rubor and cellulitis with that simple technique on the physical exam. Once we have an idea this patient may have PAD, we can go through some diagnostic modalities, such as the ABI we talked about. That is the procedure that allows us to define what PAD is. It is a physiologic and hemodynamic measurement. That's the ABI. The toe brachial index is a part of that ABI that we can do. We can do segmental pressure, so patients can have, instead of the one cuff at the ankle, we can go to the vascular lab and place 3 or 4 cuffs on the leg and give an idea of where these lesions may be. And pulse volume recordings are important, or plethysmography, to kind of determine the volume of muscle change or flow change under the cuffs and give an idea in patients with more calcified vessels where their disease is located. We can measure tissue oxygen perfusion with transcutaneous oxygen pressure, and that's putting some pads on in a specialized vascular lab to determine how well blood is flowing to that tissue. There's anatomic imaging. So we talked about physiologic imaging with ankle brachial index, but the anatomic imaging would be duplex ultrasound, magnetic resonant angiography, CT angiography, or digital subtraction angiography. That's an interventional procedure. In the vascular lab, that's kind of an extension of our physical exam as vascular surgeons, having these patients go to the vascular lab for their ABI. These blood pressure cuffs are placed on the both arms, and you can do it on both calves, or sorry, both ankles, or you can have a 3 or 4 cuff method along the entire leg. And you take the highest brachial index, the highest arm, and you're dividing that into that ankle index and getting a ratio. And there should be about 100% of the blood flow or slightly more to the legs. And this is where you can see those numbers of claudication being zero point 0.4 to 0.89, rest pain being 0.2 to 0.4, and tissue loss can be anywhere below that 0.5, zero point 0.4, but typically when you're getting in that 0.2 range, you're looking at tissue loss. And then if the patients are non-compressible, if they have hardened vessels or diabetic, these ABIs can be falsely elevated. You might have someone in your clinic with an ABI of 1 or 1.2, or may even be 1.6, and we know that's false, but it could be falsely elevated, and they can be a little worse than you thought, and a toe brachial index may be the next step. Segmental pressures is that 3 and 4 cuff technique, which we'll get to in a second, and that can establish the level of disease. We can analyze the waveform, especially in these diabetics, to help us analyze location of disease. And exercise testing may be in someone who may be slightly younger, in their 50s or 60s, and they don't really have the pain until you stress them, and we can put them on a treadmill for their ABIs. And this is an example or a picture of the 4 cuff method along the legs, and these blow up in a sequentially and give readings with this sensor on the foot to see where the lesion may be located along the lower extremity. It's non-invasive, it's rapid, and it's very sensitive and specific. As you can see here, 95% sensitivity, 99% specific, and an ABI again of less than 0.9 is diagnostic of PAD. It is a very good tool. Also, being it's non-invasive and rapid, we can assess disease progression, and this is what we use to follow these patients once they are diagnosed. This is what an ABI at the ankle would look like. These patients have ankle cuffs, and in this particular patient on the right, a 0.96 on the right, a 1.13 on the left. And you can see their waveforms are they're good waveforms. They're peaked. They have a dicrotic notch, if you will, and they're not widened. So this would be a very normal arterial brachial index. And the other thing to point out is between the arms, we look and see if there's any difference between the arms, because that can give us an idea if they have upper extremity peripheral arterial disease. Toe brachial index, I mentioned it earlier. That's a little more specialized, where you have this sensor on the toe and this cuff on the toe, and you're listening to the signals, or sometimes there is a photoplethysmography device to measure this. But this is good in patients who have hardening of the arteries, or diabetics who typically their toe vessels are spared from calcification. And we can use the toe brachial index, and a normal would be greater than 0.7, whereas less than 0.4 is severe PAD, or the critical limb ischemia, or chronic limb threatening ischemia we talked about. An absolute pressure greater than 55 correlates well with an ability to heal a foot ulcer. Segmental pressures, I showed you the ABI earlier, but this is more of what we look at for segmental pressures. You can see the difference in the arms. They are very similar. The cuffs, as we go down, we see there's an ABI of 1 at the thigh, and it stays 1 all the way down. So there's no difference between the thigh cuffs. Usually we use a number of 20 between the cuffs. If there's a more than 20 millimeter of mercury drop, then we think there may be disease between these 2 cuff segments. And we also can look at these waveforms in patients who are diabetics. Exercise testing, the standard protocol is putting them on a treadmill at a grade of 12%, rate is 2 miles an hour, and a time for 5 minutes. The tech is noting how long they last, how long until claudication happens. They note any change in the arm pressures or the leg pressures. And typically, once they're on the treadmill, they get off and they keep the cuffs on while they're on the treadmill so they can get off immediately and get hooked up to the machine and get tested. This is what an exercise testing would look like after this patient walked 5 minutes. There were no symptoms, and the test was terminated with the end of protocol. You can see this is the brachial going up, which is what you'd expect. And the left ankle slightly goes down, but not much. And the right ankle, this is more of a normal response in a normal person that you may get elevation because you have vessel dilation. So that's a normal exercise testing. And then maybe an abnormal, I place this in to show that the brachial actually, these patients are at rest. They have actually, this is, sorry, I said abnormal. This is normal. These patient has a lower right ankle pressure starting off, and they don't drop during the exercise, post, or throughout their rest time. The brachial goes up and then comes back to baseline as well. No symptoms on that patient. I put this in, this exercise testing. This was the abnormal one, sorry. And you can see at the beginning, this is the blue line, the right brachial. It actually goes up as it should and stays pretty flat. But what you see in patients who have disease is that they start off at rest and they drop pretty quickly on the post-exercise. And then hopefully over the next 5 to 10 minutes, they come back to baseline, and that's what you're looking for in these patients who may have abnormal exercise testing. When we talk about ABIs and PVRs, that's pulse volume recordings. These are patients who may have hardening of the arteries, and I chose this image to show you an abnormal one. In this patient, their brachial pressures are the same between right and left, but if you look at their high thigh pressures, they're 60 and 60, 62, 67. So their ABI is 0.4 and 0.39, or around 0.4 in both upper thighs. This is severe disease in the aortoiliac segment. And you can see that that's just an example of a very abnormal ABI. And what we can use as waveforms to show you this dramatic. This doesn't have the straight up and down peaks that we would look at, or that dicrotic notch. They're widening out. So we're starting to see some mild disease here, mild to moderate disease. And when you're getting down here, these waveforms are flattening out and you're losing any of that upstroke. And this is what we're looking at in these patients who have hardening of the arteries and maybe falsely elevated ABIs. That is not the case in this particular image. It's just an example. So when we move on past the physiologic response or physiologic studies, we can look at anatomic imaging. The next step and my go-to would be a CTA with bilateral lower extremity runoff, or ultrasound would kind of be my next step. But when you're trying to delineate the anatomy, CTA is one of my favorite tools because you can get a 3D idea about these patients' anatomy. It'll let you know about calcification, the degree of occlusive disease, status of the femoral arteries. Now, the limitations on the CTA, as you well know, are the radiation and the IV contrast. If you think about an MRA, though, in patients who may have kidney problems, that's not an ideal test either because of the nephrogenic systemic fibrosis that could occur with the gadolinium. So you have to think about that as well. And then finally, angiography is, the traditional gold standard, and I still think it's a great tool, but CTA is used a significant amount in my practice. And with angiography, we can use contrast, but in patients with kidney disease, can use CO2 angiography to decrease that contrast amount that they get. For an example, this is a 3D CT scan reconstructed, and this is an angiogram in that same patient. And you can see the level of detail in our 3D reconstructed CT scans related to our angiogram, which is the gold standard. So I think we're getting really close, and we use these interchangeably, these tools interchangeably, and to assist each other. Duplex ultrasonography, I said that's usually my next go-to because it's non-invasive. It can give you, it can delineate arterial lesions. You can look at them with Doppler, which is how our flow is and how compliant the vessel is, and how, if there is any flow, you can look at color. And you can look at the morphology. You can see that this vessel here particularly has a stent in place. So it picks up a lot of detail if you have a great tech, and we're lucky to have those. So next, if you have these patients that you've now decided they have what appears to be critical limb ischemia or a peripheral arterial disease, um, somewhere along that the peripheral arterial disease spectrum, and we've diagnosed it and use our testing modalities we talked about. How do you treat these? Well, the treatment goals, prevention is the key. It's all about modifying risk factors in these patients, and you want to minimize the risk of these other cardiovascular related events. Pain control, wound care, and foot care is critical, because if these patients stub their toe on the corner of a coffee table or cut a toenail too deep and they're diabetic and they don't have great blood flow, that could likely lead to loss of limb. And then ultimately, if they needed effective revascularization, and that's kind of what we're getting into. With medical therapy, smoking cessation is critical. Smoking cessation is critical. It's key. I talk to my patients all the time about this, because that's the top 10 reasons to have peripheral arterial disease, I believe. Glucose control, with hopefully in hemoglobin A1C is less than 7 in these patients, and that's something we can work with their endocrinologists and primary care physicians with. Blood pressure control and exercise program is absolutely key. In a patient who has claudication, their risk, and we'll talk a little more, but their risk of amputation is very low, probably somewhere around 3 to 5% over the next 5 years. And these patients have a little higher risk undergoing a procedure. And if they're not lifestyle limiting, or this is not affecting their ability to work and provide for their family, then exercise programs are critical in these patients, I believe. These exercise programs, if done properly, and they're covered by our insurance company, most insurance carriers now, because they've been shown to be very important, can increase collateral circulation to the leg, and maybe these patients can get through and improve without surgery. And it adapts to changes in their muscle enzymes, their Krebs cycle, and their anaerobic pathway to allow the muscle to work more efficiently. And with pharmacotherapy, these patients, every one of them, I have them on, if they can tolerate an aspirin or a statin, or possibly a Plavix, so some type of antiplatelet agent, statin therapy, smoking cessation, exercise. I think those are absolutely key. This cilostazol I placed here because of it's one of the only vessels, or one of the only medicines we've seen out of this category, the PD3 inhibitors, where there may be some vasodilatory effects and improve flow to the lower extremity. There have been some studies suggest that's okay. There have been some studies suggest that it doesn't improve at all. And you have to be careful with Plital or cilostazol in patients who have heart failure, because these patients can actually have worsening heart failure symptoms with this. So this is something that you can work with their primary care physician and see if it's something you want to do. Personally, I don't prescribe Plital or cilostazol to my claudicants. I don't think there's anything wrong with it if the patient can tolerate it, but that's just not generally my first line. It's usually exercise therapy, stopping smoking, and aspirin statin. So like I said, decision-making for claudication, the 5-year outcomes, I kind of alluded to this, the limb morbidity and mortality. You can see these patients, only about 1 to 3% will go to critical limb ischemia. Most of them will be stable at 70 to 80%, and about 20% of them will worsen over time. And this is a little bit of a larger diagram showing how these patients 5-year with their limb morbidity and mortality. I mean, this really is a very low, some people even suggested even as low as 3 to 5% over 5 years of risk of limb loss with claudication. And that's the reason we typically try to treat these patients medically or non-operatively if they only have claudication. So the considerations again for treatment would be multi-level disease. If these patients have multi-level disease, we typically can make them feel better with treating 1 or 2 levels of that disease. The distribution, as we talked about, is different in young people versus older people, and we already mentioned that. In these patients with multi-level disease, you got to treat the inflow first. Treatment of one level disease. So if this patient had iliac disease and SFA disease and tibial disease, and they had rest pain or lifestyle limiting claudication, sometimes just treating the iliac disease or femoral disease as the inflow will alleviate their symptoms completely. If these patients have tissue loss, they have ulcers in their toes, the goal is inline flow to the foot. So there should be opening the inflow like iliac or femoral, and there should be a bypass to that lower extremity to try and get flow directly to the foot for healing. Otherwise, they're at increased risk of limb loss. So the treatment modality, there's no perfect treatment in peripheral arterial disease for every person. This is it all depends on location, extent of disease, degree of ischemia, and it's really a customized approach to every patient. What are our strategies? We can simply break it down to a surgical approach. And in this approach, we simply have like a bypass or an endarterectomy or an endovascular approach. And that's some people say the minimally invasive approach. We have a lot of tools in that bag as well. And as vascular surgeons, we can do both. There are some specialties that do one or the other. And I think we do both and can actually look into to see where there is a benefit of one over the other, because we're not biased on one approach or the other. I think we're skilled in either way. The endovascular approach, we have balloons, we have drug-coated balloons, we have bare metal stents, drug-eluting stents, atherectomy devices. There are lithotripsy devices. I mean, there's so much around the corner with endovascular approach. And that's and how do we choose when you're talking open surgery versus endovascular surgery? Well, it'd be hard to discuss that without discussing our basal trial. It's the bypass versus angioplasty and severe ischemia of limb, so basal trial. This was a randomized trial in 2005 published. It had two arms. It had looked at balloon angioplasty and bypass at 27 centers in the United Kingdom, and had two endpoints: amputation-free survival and overall survival in these patients. These patients had severe ischemia, either that rest pain or the tissue loss we talked about, for greater than 2 weeks duration. And when you look at their amputation-free survival or death, there was no significant difference between the endovascular or the open surgery at 21% in the bypass and 26% in the balloon angioplasty. However, in that study, surgery was associated with a higher morbidity. Here are some of the charts or graphs from that. The survival curves from the basal trial of the Lancet, where we're looking at amputation-free survival on the left and overall survival, and there's really no difference, no significant difference over time between the balloon or the angioplasty or the bypass surgery. It is the landmark trial for evidence-based practice in advanced critical limb ischemia, and the long-term outcomes just suggest, like we talked about, similar limb salvage rates between endovascular and open, or no overall survival difference at 2 years. What it did suggest, if these patients were alive at 2 years, then bypass surgery group had a longer survival because those patients had selected themselves as being healthy undergoing open surgery. So when we look at this, what do we take from this? Basically, this study showed, it was one of the first to suggest that balloon angioplasty, that's that PTA, percutaneous transluminal angioplasty, balloon angioplasty and bypass are not either or therapies, that they are complementary therapies, and you can do one first or the other one first, and or we can mix as a hybrid approach to these patients and create custom approaches for these patients. And I think that's what this lends to us. So the surgery advantages is that So typically advantages for surgery are that durability is longer for venous graft bypasses. So the patients have to have some sort of venous conduit, I think, for the best outcomes. Survival actually may be longer in less sick patients and who may survive up to 2 years. And the limitations for surgery is that a lot of these patients present to us now, we're seeing a lack of arterial outflow. So they don't have good tibial runoff into the foot, or they don't have any targets at all to bypass to. These patients now we're operating on much older patients. I mean, it wouldn't be unusual to see a lot of 80-year-old patients getting bypasses now because they're living longer. And these severe comorbidities these patients come to us with. And they may have widespread necrotic changes that prevent us to do the bypass. And a lot of these patients have lack of venous conduit for their multiple other comorbidities. They've had multiple IVs, or their veins just are too small to undergo for use. The conduit choice, I'm just telling you my personal opinion is that the type of conduit, well, this is not my personal opinion, but the conduit type is a major determinant of long-term graft patency. As long as the patient has good inflow and good outflow, this conduit I think is critical. Typically, I like to use autologous vein. And I usually will select these veins if they're over 3 to 3.5 millimeters in diameter. The great saphenous vein, small saphenous vein, I will use cephalic or basilic vein in these patients. And our other option is prosthetic, whether it be PTFE or a fabric, a Dacron fabric. And I think that in my opinion, vein is superior and should be used whenever it's possible for many different reasons. These are some graphs or some charts I pulled from our Rutherford 8th edition, just looking at the difference between conduit choices. And in the above knee, there's been a lot of debate. Some people actually will just prefer to put a PTFE bypass in a patient above knee because it's a lot easier. You don't have to harvest vein. And there are some studies that suggest that there are similar outcomes. But looking at this chart from our Rutherford edition, you can see the above knee popliteal Dacron versus PTFE. This is not looking at vein, it's just looking at different prosthetic types. And that there's no significant difference between any of the prosthetic types used. So I think your preference is actually your preference, and you're going to have very similar outcomes. If you're looking at human umbilical vein or a cadaver vein versus PTFE, there was no significance over time in a couple of studies, but I think it's majority of people said there was no significant difference between PTFE and human umbilical vein, and there was one study in 1987 that had a significance between the two. I think that most of us all agree that if you use a PTFE below the knee, a vein cuff should actually be used. These are a couple of options from our Rutherford 8th edition. There are, and no means all of them. They're significant. In fact, the technique I use is a Linton patch or modified Linton patch, but there are these other patch techniques you can see here. But there is no significant difference above the knee with this vein cuff, but there's a statistically significant difference using this vein cuff when you use prosthetic below the knee. And then when you compare above the knee vein versus prosthetic, there is a significant difference in multiple studies when you're comparing the two, whether vein or prosthetics used. I think that my opinion is that vein is better anytime it's available. So I use the vein that is there, the best vein that's available at the time of that surgery. And I think you have lower risk of infection. I think you have better outcomes with vein when you can use them. The appeal, however, if we switch gears to the endovascular approach, though, is that it is relatively safe and minimally invasive in nature. There is a lower major adverse event rate at less than 5% and higher technical success rates. So greater than 90% of these patients that are selected out have great success rates. It can be done in high-risk patients where a bypass may not be necessarily ideal, and we have pushed this field a great deal over the past few years. And limb salvage rates are comparable to surgery. It's cost effective. And reintervention can be offered for late recurrence with the similar low morbidity and mortality. And you can use this as a hybrid approach or a first or second approach when there's been an open surgery performed as well. So that's kind of our workup for peripheral arterial disease. And since I talked about critical limb ischemia, and I differentiated with chronic limb-threatening ischemia in these patients who have diabetes. And I'm going to kind of switch gears, but still stay in the same vein of peripheral arterial disease, and discuss aortoiliac disease evaluation and management. And we're going to cover some very similar topics going through these next few slides as well. So aortoiliac occlusive disease is just that. It is a variant of peripheral arterial disease, or a subset of peripheral arterial disease. It typically affects the aorta and iliac segments of the vascular tree. And if you think about it like a house, you have a garden hose, which is your vessels out to the garden potentially in the foot. And I think the aortoiliac segment is like the faucet on your house, that if it's blocked off, you're not going to get blood flow, or you're not going to get water out to your garden. So you really have to turn on this faucet by opening up these vessels to get flow out to the lower extremity. Again, PAD affects up to 12 million Americans. And as the population ages, we have more and more patients with PAD, and I think we're going to see, and we see a lot more of these patients with aortoiliac disease as well. Again, the presentation is very similar. About half of these patients are asymptomatic, and even though they may be occluded or narrowed in their aortoiliac segments, this may have been a chronically occurring process, and these patients may not have any problems or very minimal problems with their lower extremities. They present very similar, and the terms are similar. These patients have claudication, which is cramping pain, except these patients typically have cramping pain in their thighs and buttocks. Calf pain is rarely alone. If they have calf pain in aortoiliac occlusive disease, it's more common with combined multi-level disease. These patients also may have erectile dysfunction, and that's difficult to parse out since a lot of us as we age may have erectile dysfunction. But there's a classic Leriche syndrome that we all learned about as we go through our schooling. But Leriche syndrome is specific to aortoiliac occlusive disease. And when we say that, we mean someone who has decreased femoral pulses due to an occluded or narrowed iliac segment, aortoiliac segment. Someone who has buttock pain because they're losing that blood flow through the iliac vessels into the pelvis. And someone who may have erectile dysfunction. So this is the triad of Leriche syndrome and the aortoiliac occlusive disease. That would be a classic presentation. These patients also have critical limb ischemia, or may have critical limb ischemia with rest pain or progressive tissue loss over 2 weeks. And it's more common when combined with a femoral popliteal disease. One other thing that could also happen in any of the peripheral arterial spectrum is blue toe syndrome. We see it a lot with aortoiliac occlusive disease, though, or we may see it a great deal with that. It's someone who may present with these kind of satellite lesions, or hemorrhagic or petechia, splinter hemorrhages, or whatever you call it, trash foot. But this is a patient who have atheroembolization from hardening of the arteries somewhere upstream between the heart and the toes. This calcium or plaque or thrombus or emboli may actually break off and go to the toes. These are generally tender lesions. The patient complains of tenderness in their foot because these are acute ischemic lesions where this trash, if you will, kind of ends up in these distal extremity vessels and causes tissue necrosis. So if you see that, you got to think upstream. There's something that could be occurring, and it may be atrial fibrillation with thrombus in the heart, but it may also be aortofemoral disease, and just palpating the femoral pulses may give you what you need. Again, the risk factors, you've seen this chart, or this risk factor chart. It's the same thing, very similar. Smoking, diabetes are about 4-fold increased risk. The workup of aortoiliac disease is very similar with you start every workup, no matter what patient we're talking about, with a history and physical exam. Use the non-invasive hemodynamic measurements. You can use PVRs, ABIs, ultrasound imaging, and then you can delineate the anatomy with that ultrasound imaging or axial imaging like CT scan, MRA, or arteriography. The physical exam is similar, can be a little different, but you typically have diminished pulses. Typically, these are diminished femoral pulses, a little more proximal. There may be a bruit present over the lower abdomen or the groins if you listen with your stethoscope. These patients who have had chronic occlusive disease may have atrophy of the lower extremity, musculature, hair loss in the legs and toes, as we talked about earlier, dependent rubor. We showed that video a moment ago, and pallor on elevation. They can have gangrene or chronic ulcerations, that atheroemboli we showed, or one of the things that I like to discuss with my residents is that maybe these patients, we really have to get them to palpate the femoral arteries, because some of these patients will have aortoiliac occlusive disease but will have palpable pedal pulses because of the rich network of collaterals that we have. And you can see here's a picture of the abdominal aorta, and the connection here of the iliac arteries is absent, but there's significant blood flow in the external iliac arteries and out, and the inflow doesn't look too bad. And it's because this patient has developed so many collaterals through the inferior epigastrics or these mesenteric vessels that these patients could easily have palpable pedal pulses. And that owes to our massive circulation and collaterals, where you can have intercostals, subcostals, these deep iliac circumflexes, these pelvic vessels. These all connect to give us our collateral circulation to our feet when you have aortoiliac occlusive disease. How do you work these patients up? Very similar. You start with that history and physical, and then when you're looking at these patients, that extension, that vascular laboratory is an extension of our physical exam. On this picture, you can see the aorta segment and the iliac segment, but on the left, that iliac segment is missing. And with the ABIs, we can actually tell the difference. Actually, between the brachials, there's a large difference. So there may be disease in the brachials themselves. But if you look between the upper thighs, there's a 1 ABI here, and there's a 0.55, 50% on the left. And that really points out to that. And just to show you, after this patient underwent an aortobifemoral or an aortounifemoral bypass and a uniiliac on the other side, they had return of flow. So if you see not so much difference between the brachial, which we didn't do anything with that, but you can see the differences down the lower extremity. They're equal all the way down, and that patient was treated. So what are the treatment options? Again, medical therapy. So these patients should be risk adjusted, and their more cardiovascular risk should be optimized. Direct reconstruction, we'll go through all of these, but aortoiliac endarterectomy, that's a direct opening and cleaning out. Aortobifemoral bypass, so aortobifem. Laparoscopic, there are some people that have reported a laparoscopic aortobifemoral bypass, but that is definitely not the mainstream, and you probably won't find many people, maybe even just a couple of people in the world who do that. Extra anatomic reconstruction is important for surgeons to understand in patients who may have infectious processes and need extra anatomic tissue. We can come from the axilla for axial bifemoral bypass, axial unifemoral bypass. Femoral femoral bypass is going across the pelvis. Thoracofemoral, with opening the chest and bringing our bypass from the chest, the aorta in the chest, or the thoracic aorta. And then endovascular. So now we've improved so much with endovascular, means that we can perform an endovascular aortobifemoral bypass without operating or without opening people's belly. And then endo-remote endarterectomy. Again, medical therapy, smoking cessation, exercise program to improve those collaterals, to change those enzymes in those muscles, the pharmacotherapy, aspirin, statins, and critical for foot care. And these management options definitely depend on presentation. If you have a patient with claudication, they may not want to have surgery, and that's not a wrong answer. But these patients typically do well. If they're asymptomatic, you can monitor these patients in your clinic. In patients who have claudication, these patients should undergo, I believe, a supervised walking regimen to try and improve that claudication. And if they have lifestyle limiting claudication or trying to improve their family or trying to provide for their family, surgical option may be something to push their treatment along so they can get back into the workforce. And then rest pain and tissue loss, it goes without saying, I think in patients who have rest pain or tissue loss with that, they still have that really high risk of limb loss. That quarter of the patients in a year may have limb loss. They may need to go on for surgical management. The options could be aortoiliac endarterectomy. This is probably appropriate for less than 5% of our patients that come through the door. I mean, you won't see this often, but it's commonly performed in these middle-aged females with occlusive disease in the mid-distal aorta. They have limited extension. These patients with unstable focal plaque that may be embolizing to go in and get these out. And the advantage is you're avoiding putting a prosthetic in these patients. And this is kind of less appealing for men because of getting this aorta cleaned off. You're going through these nervi irrigentes, and if injured, may cause sexual dysfunction such as retrograde ejaculation. But I think at that point, if you're operating because they are having significant peripheral arterial disease, that may be the least of their worries at that time. Here's an image that of a patient where this is the aorta. The head is here. The aorta splits into our iliac arteries, and you can see that aorta has been clamped and opened up longitudinally. The aortoiliac disease has been, it has been endarterectomized, and you can see now from here having this thickening. This aorta has been endarterectomized, removing the total endarterectomy specimen, opening up, and then reapproximating the aorta. Sometimes these are patched, and in this case, there was a primary repair performed. Aortobifemoral bypass is more of a classic operation. I think I put here in quotes the gold standard, and the mortality rate here and this is about 1 to 5%, and some centers are less than that, and we're fortunate to be one of those centers. But you get excellent long-term patency rates, and that's 85 to 90% at 5 years. These things will still be open, so it's one of our better bypass surgeries, almost a fix it and forget it approach. And then this is what it may look like with different variations. But if the head is here and the feet are on this to the right of the screen, the aorta is difficult to make out, but it's here, and you can see how that aorta bifid bypass has been sewn in place and tunneled anatomically. Aorta bifid bypass configurations. This is kind of an important point. Whether you do an end-to-end, that means taking 2 lumens and sewing them end-to-end, or whether you take the bypass and doing an end-to-side. Where would you do one over the other? In a patient who has an occluded common iliac segment or inferior mesenteric artery, and you have no worry about wanting to get flow into your hypogastrics from an antegrade approach. An end-to-end is fine. I find it a little bit easier, and I think it is. I think it actually is a little more conducive to just the way the normal flow. And when you do your anastomoses into your femoral arteries, you're going to get retrograde flow into your hypogastric arteries or internal iliac arteries to feed the pelvis if those are open. And then when you go into side, the reason you would choose this, if you have a patent IMA you want to keep open, or if you have patent hypogastric arteries you want to keep open, you would go into side so the native aorta is still feeding your native vessels into your pelvis and your inferior mesenteric artery. And then your retrograde, it's when your external iliac arteries are occluded and your retrograde flow would not have done that for you. Endovascular therapy, move into that. There's the same options we have for endovascular therapy, that being balloon angioplasty. That's kind of molding open it's a controlled dissection, basically opening this blood vessel. Stenting, we can do balloon expandable stents, self-expanding, and they're drug-eluting stents. Stent grafts are typically stents, metal stents with fabric components. Um, Atherectomy, lithotripsy, and some of the advantages here are less invasive, less morbid, less mortality. But the disadvantages are we worry about the decreased patency for long lesions. I think that's kind of we're closing the gap here. Restenosis is key is an issue, and the common femoral disease. If you have disease in the common femoral, at least at this point, I think it's better to for open surgery, as we'll talk about in a moment. For aorta bifemoral bypass or endovascular approach to that, I don't think you burn any bridges in these patients if they, if they are an ideal candidate or a candidate for endovascular. I can show you there are some patients that you would think would not be a candidate. If you take a peek here at this aorta, the iliac arteries are occluded, and you would think, if you on quick, this may be external iliac, but it's in fact the internal iliac artery. The external iliac is occluded from here all the way down to its reconstitution of the femoral. And the common iliac artery is occluded on the left side. And this is one of our post-operative results in that exact patient, where we were able to balloon and stent these patients open, improving flow to their lower extremities with nothing more than either small femoral incisions or small percutaneous puncture sites, but being able to stay out of the abdomen doing the bypass. Endovascular management of these is definitely picking up and has been picking up for a couple of decades. This is a paper out of the Cleveland Clinic discussing endovascular management of iliac artery occlusions. And these are TASC C and D lesions. I didn't talk about TASC C and D, so I'll just say these are lesions that are more difficult lesions that maybe initially they were thought to only be managed open, but we can show in the Cleveland Clinic's experience that when they looked at aortoiliac disease, these patients were similarly looked at 92 procedures with iliac stenting, 66-year-old average. About over half of them were male, and we were successful, or they were successful at 91% of the procedures. The key part here is about a quarter of these patients had open femoral endarterectomy, because if you stent iliac arteries and you don't improve the outflow or that femoral artery, then you're going to just be pounding against an occlusion, and those stents we don't believe do as well. But you can see when they're managed appropriately, even these difficult lesions, up to 3 years, there's 76% patency with no difference between difficulty of the lesions. Secondary patency is even more, 90% at 3 years between the different groups. As your lesion complexity goes up, it didn't really matter. There was no significant difference. Predictor of our presence of diabetes was a negative predictor of their patency, but age over 60, smoking, male sex, hyperlipidemia, and renal function, it really had no effect on predictors of patency. Another study out of the Cleveland Clinic compared outcomes and durability of doing these endovascular aortobifems and stenting versus an aortobifem, the gold standard, if you will, for iliac disease. And you can see the patients very similar between the bypass and the iliofemoral aortobifem, iliofemoral bypass, or balloon angioplasty and stenting. The aortobifem bypass patients were actually younger, because if they were younger, if they're going to have a big bypass, they should be healthier and be able to undergo an open surgery. The aortobifem bypass patients had higher cholesterol. There were more smokers in the open surgical group. But the ballooning, we noted again that about a quarter, about 21% of these patients, a fifth or a quarter, needed open endarterectomy and profundoplasty with their bypass to improve on the endovascular results. When you look at their limb-based primary patency at 3 years, It was significantly higher for the aorta bifem at 93% versus 74%, and that's significant. But with secondary patency rates, there was no difference in primary patency of those limbs. So uh, with a further procedure, keeping these stents open, there's no difference in their primary patency. Limb salvage was equal at 98%, and their diabetes mellitus and the need for distal bypass were associated with decreased patency. This has even been looked at for chronic total occlusions of the infrarenal abdominal aorta. And in 2009, it was a paper out of the Cleveland Clinic as well, showing technical success in managing chronic infrarenal total aortic occlusion was 93%. And about 9 of these patients, about 30%, had lysis, like lytic therapy, prior to stenting. There was no mortality in this study, and there were 3 technical complications with an iliac injury or a limb thrombosis that had to be re-intervened on. The 12-month follow-up demonstrated no limb loss, and the primary patency at 1 year was 85%, 3 year was 66%, secondary patency was 100%, and 3 years was 90%. So it shows that this is a great option in these patients, and I don't believe it burns a bridge, so to speak, where there's always open surgery in the patients who are healthy enough to tolerate open surgery. What are the contraindications to doing an endovascular first approach in here would be relatively few, in my opinion. I think prior surgical intervention with ligation of the native circulation, so let's say that end-to-end bypass, may be that would be a contraindication because the native aorta would not be connected anymore. A coral reef plaque is a relative contraindication. If you understand, that's that significant plaque around the mesenteric segment. And in my opinion, this is best treated with an open surgery in a good risk individual. So that would be, and then my treatment algorithm, I believe in most of these aortoiliac segments is endovascular first, if the patient can tolerate it. Recanalization and primary stenting, using an arm and leg approach as needed. Recreate a neo-aorta with recreating this aortoiliac stenting. Do not raise the bifurcation. And in patients with chronic total occlusion, we've kind of learned for lysis to create a channel so that if the thrombus is up to the renal vessels, that the bits of thrombus that are breaking down don't get flushed out the renals and hopefully get flushed downstream instead. And treating the concomitant common femoral disease is really important with any of these aortoiliac interventions, and we note that to be about a quarter of the patients that undergo this procedure. If the patient has critical limb ischemia and need salvage of their toes, a distal bypass is to improve blood flow circulation to heal any wounds. A distal bypass may actually be needed. An example of that would be a sheath coming in from the arm into a total occluded aorta. This is a picture to demonstrate how we have come in from the brachial approach down the aorta and into this occlusion. If you can drill through that occlusion and get your catheters on each side, we have a snare where we can snare that wire and bring those wires as a body flossing technique. And once those wires are through, you can kind of drive anything through those. And typically you're going to get this neo that's almost an aorta bifem, but we're doing it from the inside of the vessel. In this presentation, I have a couple of examples. If you're interested in seeing a couple of outcomes, and just showing how we manage peripheral arterial disease with some endovascular techniques, and having some photos of how maybe some of these feet have healed. This is one of the cases where we had, I think I showed it earlier, with comparing the aortoiliac disease in a CTA versus angiogram, but you can see this occluded iliac vessel. This may have been only treated by aortobifemoral bypass in the past, but if you have a patient who's sick and can't undergo open surgery, or and in my opinion, I think endovascular first approach in this would be how I would approach it. This is a patient we were able to access the right femoral artery. As you can see, my access wire. Unfortunately, when your wire starts coiling, we call it barber poling, it may be dissecting around the outside of the artery. So it's not really getting into the lumen, it's just dissecting on the outside. However, in these patients where you cannot get around from the bottom, you can always come from the top and stack your sheaths and catheters and hopefully drill from the top plaque. Sometimes these plaques are a little bit more, a little easier to get through. And again, that picture I showed you, we can connect, snare the wires. And this is a picture where we've come in from the bottom, we've snared, and this is a picture where we are snaring that wire, in fact. And after that wire is snared, we turn our attention to the other iliac artery. And once that happens, you can have your sheaths up through those occlusions. Once those sheaths are up, you can serially balloon and dilate and stent these patients. And you can see my stent's in place, my wire's in place. I've confirmed I'm in true looming. These are marker tip sheaths, which are important because you want to make sure you know where the end of your sheath is when you're deploying stents. And this is a patient where we were able to deploy iliac stents extending into the aorta. If you can remember where we were before, this entire segment of the aorta is occluded, and now we have flow into the femoral arteries and to the legs. And then that's just one more example of that. And I'm going to show a couple of examples of peripheral arterial disease. And then we should be able to conclude this presentation. This is a 67-year-old male who was poorly controlled diabetic. This right foot wound you can see here. This foot wound was debrided by a surgical colleague, and I was called in for an evaluation to see if we can get better blood supply. Well, as you know, these diabetic wounds are very difficult to heal, and a lot of an amputation patient for sure. But he noticed this, or his family did, 2 to 3 weeks after stepping on a foreign body. He has no sensation in this foot. He was treated for cellulitis, and in this case, just treated with antibiotics for a couple of weeks with this wound that was festering. And a white count was around 15. The hemoglobin A1C was obviously uncontrolled. And this was in March. This is the debridement I was able to perform on this patient. It's a little bit deeper, as you can tell, and all that dead tissue has been removed. This is another shot of that, another angle to see how deep that wound goes. It almost goes to the other side of that gentleman's foot. When we performed an angiogram, you can see that if I can slowly go through here, that the common femoral, profunda femoral, and SFA are widely patent. As you see, classically in diabetes, the tibial disease are where your problems arise. And you can see multi-level tibial disease throughout this lower extremity. Still shots of those tibials show that there is occluded anterior tibial at takeoff, very narrow posterior tibial artery, and the perineal is significantly narrowed throughout its length. I attempted plain old balloon angioplasty throughout this patient's lower extremity first, and it didn't quite pan out. It just didn't improve. His velocities didn't improve, and he was brought back about a month later. And he ended up undergoing orbital atherectomy. And I don't do this. Initially at all the time, but I do it in cases where there's severe calcified disease. And you can see here that initial lesion here at the posterior tibial takeoff, we were able to open up quite nicely. And then some of these other diseases where we were able to open up and show that we could get better, improved flow into the foot. This was the foot again during that same hospitalization, though. And then I did debride it a little more because that slough in the bottom did not look great. So if we can, and this is a picture 5 months post-op of this gentleman where he's been mostly non-weight bearing. You got to keep the foot clean or the wound clean and dry and evaluate monthly for wound healing. We can have excellent results with improved revascularization. So maybe we can stop cutting the legs off of some of these patients. This is another example of a patient that you may see where you get that call of the kind of soupy wound. The patient had a resected metatarsal, ended up with non-palpable pulses. This foot was in jeopardy. You can't tell you that how bad it smelled, but it was just that purulent smell, wet gangrene now. Unfortunately, this patient had elevated troponins. Had 3 drug-eluting stents placed because right after these surgeries, the patient had a massive MI or a STEMI, ST elevated MI. So this is a picture of her aortoiliac segment, which actually looks pretty normal. I'm going to run this angiogram on the screen here, and you can see the profunda and SFA are not abnormal. But until we get here, where we have some narrowing in the distal SFA and significant narrowing in the popliteal artery, where there's occlusion in the popliteal artery, and you start seeing collateral blood vessels. There's reconstitution via significant amount of collaterals via the posterior tibial artery, as you can see, that runs into the foot. This is one of those patients, as we tried significantly to get through from the top, we just could not get through this lesion. They're kept to be dissecting. And other options to show you are retrograde access. So endovascular options are growing and growing. We have other options. We can come backwards with our wire, and sometimes it's easier to go through our distal approach and recanalize a wire into open segment. If we can get a wire through that, a lot of times we can balloon angioplasty this and open up these tibial vessels, and it may be enough just to heal those wounds, as you can see. And this is our runoff into the foot at this time. Unfortunately, that didn't last a long time, but it got us through several months of foot healing until she improved from her myocardial infarction, and we ultimately put this patient in for a femoral to below knee tibial bypass with vein, with a in situ saphenous vein. And you can see as this foot goes through its timing here, over a few months, we went from that soupy wound, even to here it looks better, to a very small wound that ultimately was grafted, and she left with, or this person left with a intact foot.